بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد الأمين وعلى آله وصحبه وسلم أجمعين ومن تبعهم بإحسان إلى يوم الدين. السلام عليكم ورحمة الله وبركاته، وأسعد الله مساءكم وصباحكم بكل خير بحسب توقيت البلدان التي أنتم فيها. نرحب بالأخوة الضيوف المتحدثون بهذا المؤتمر النقاشي، وبكم جميعا المتواجدين معنا بالقاعة الإلكترونية عبر برنامج الزوم وعبر البث المباشر من قناة مبادئ حضارم لمكافحة كورونا عبر الفيسبوك. وننقل لكم السلام والتحية من جميع منتسبي وفرق المبادرة والفريق القائم على إعداد هذا المؤتمر النقاشي. اليوم نحن بالأسبوع الخامس من البرنامج العلمي للمؤتمر الطبي في حضرموت لمناقشة وباء كوفيد19. ضيفنا اليوم الدكاترة الاستشاريين محمد السعدي والدكتور صالح بن سلمان، وكثير من الضيوف والدكاترة والبروفيسورات الموجودين معنا. طبعا في ملاحظة انه نحن الاستغلال الامثل للوقت نرجو انه يكون في اللي هو كتابة الاسئلة خلال البرنامج او خلال متابعتهم، ونحن سنتولى ان شاء الله نقلها للمتحدثين بحسب توجيه السؤال، شاكرين ومقدرين تعاونكم. طبعا في كلا البرنامجين الزوم او الفيسبوك حيكون في موجود معنا اللي هو الشات الحي. اسلم المايك حاليا للحوار والمودريشن لممثل مبادرة حضارة لمكافحة كورونا الدكتور القدير حسن باتيس. نسلم له المايك وعلى بركته وتوفيق المولى سبحانه وتعالى. تفضل دكتور حسن.
حياك الله مهندس احمد بحشوان حبيبنا، سعدتنا بهذه المقدمة الجميلة وبارك الله فيك وفي كل الحضور، ورب يكتب أجرهم جميعا. نرحب بكم جميعا في حضوركم أساتذتنا ودكاترتنا الكرام، ونرحب بضيفنا اليوم الدكتور محمد السعدي. تعريف جاني بالإنجليزي الدكتور محمد راح أقرأ مثل ما جاء. طبعا الدكتور محمد he will speak about lung ultrasound breath and techniques and its role in COVID-19 patient. Dr. Muhammad السعدي, Assistant Professor in Radiology and Medical Imaging Technology, PhD from Imperial College London, and academic and scientific researcher, ultrasound and expert, vascular scientist, and medical imaging solution consultant. حياك الله دكتور محمد والمايك عندك.
يا اهلا وسهلا، الله يعطيكم العافيه. شكرا للمقدمه الجميله. اول شيء انا سعيد جدا بتواجدي معكم واشكركم جميعا هذه الدعوه الكريمه، وخص بالشكر للدكتور عمر جابر، وايضا اشكر حضرموت Government Initiatives على المبادره الجميله والدعوه ولاقامه مثل هذه المحاضرات لزياده الوعي واستخدام التقنيات الحديثه في تشخيص الكوفيد-19. I will share my slides first with you guys. طيب بسم الله الرحمن الرحيم. In this presentation we are going to discuss the use of ultrasound to assess the lung and its application in COVID-19 patients, and whether it is really useful for the management and the treatment. This is my overview. First I will show you the capabilities of the ultrasound or the lung ultrasound, the critical care and emergency department. Then we will highlight the importance of using ultrasound in lung and how it becomes attractive for different healthcare practitioners. Then we will talk about the equipment and how to select your machine and probes and how to set your machine for proper investigations and diagnosis. Then we will emphasize the normal appearance of lung by ultrasound and abnormal, and also we will highlight the use of protocols for your diagnosis. Then we will summarize my presentations and then we'll give you a take-home message. As you all know, ultrasound is really an important tool, and everybody is really has the initiatives and the attractive actually to use it. And most of the healthcare professionals now using it in daily basis, in emergency department, in radiology, in cardiology, obs and gynae. So it has replaced the stethoscopes in many years now, and it can give you really not only hearing, it can give you an image plus more information, and it will help you to end up with a good or proper diagnosis to your patient. And no one can deny how ultrasound beautiful to diagnose, and the amount of information can give for us to diagnose our patients. Ultrasound has become really firmly established in acute and critical care setting in vascular access, echocardiography, and now emerging as an important tool in the assessment of the lung. And most of the emergency physician now and the intensive care unit physician also using it in their pocket to diagnose their patient for lung, and also use it as a guidance. So we believe now it has become unestablished, and nobody can deny how good is it in the diagnosis. What it needs, actually, it needs only a training and more familiarity with the appearance of the image, and get used to your machine and know how to show the normal, abnormal appearance. Lung ultrasound can be performed quickly and easily in critical ill patients, and it has a higher diagnostic accuracy than a physical examination and chest radiography. This is well established in the literatures, and there are many literatures actually and reports supporting this statement. The accuracy is more than 90%, and it has a good sensitivity, and it's really specific for the diagnosis. It enhances safety by actually avoiding asking for CT scan and more X-rays, and to reduce the ionizing radiations and the need of potential dangerous transfer in the hospitals. So you can do a bedside ultrasound and can actually get an answer with the other, diagnostic tools in your hand, like LabWorks and chest X-ray. And lung ultrasound can also be used to guide fluid management, weaning, and therapeutic procedures. And why ultrasound? Point of care ultrasound is in critical care medicine and anesthesiology is rapidly evolving and become the standard of care in multiple clinical situations, such as central venous access. And most of the physicians are using it actually to access the central veins, and actually to aspirate fluid as well. The American Society of Anesthesiology, the American Society of Echocardiography, and the Society of Cardiovascular Anesthesiologists have recently published a specific guidelines following the 2001 study of the Agency for Healthcare Research and Quality. And there are a lot of guidelines, action recommendation, where you can follow it to give or to scan your patient using an ultrasound. Multiple international critical care societies has established actually guidelines concerning the use of ultrasound in their various fields of expertise, as well as part of the residency training. If you browse literatures, you'll be able to see thousands of articles and review about the lung ultrasound. And according to my review, as you can see, there are around 12,182 an article that has used ultrasound for lung, and it's really well established, and no one can say it's really not applicable. It is really applicable and can give you really more information, and can give you a definite diagnosis actually with the help of other information like chest X-ray and LabWorks. And there are many consensus has established actually this and provided recommendation for point of care lung ultrasound, and it is available in the webs. You can go and retrieve it, and you'll be able to go through the agreement and disagreement of using an ultrasound for different lung disease. And based on my literature review research, I could say that ultrasound has reported very good accuracy, and it's really specific and high sensitivity to diagnose lung ultrasound. What machines we have, as you all know, I'm sure most of you are a radiologist, or your background, you know, some of the radiology equipments. We have different ultrasound machines available in the market. We have a portable ultrasound machines where it's really like a laptop, and we have a conventional ultrasound machine on the lower bottom. And we have also handheld devices. And all these devices now being used for scanning the lungs and various organs. And most of them actually has provided an inter-observer and inter-observers assessment validation studies, and most of them are really good to evaluate different organs. The only bit we are concerned actually is the handheld devices. I could not find really a good paper or studies that saying a handheld device is really an accurate or comparable to the portable one or conventional machines to diagnose the lung ultrasound. And this is an area of research. I'm sure we need to go further and do more research to compare the handheld devices with the conventional one, or even with advanced portable machine like CX50 Philips. It has a higher resolution and almost comparable to the conventional machines. So I would urge you, all of you, to think about it and do more research while you're scanning your patient. Try to grab these small devices and get more image and try to compare it with other machines once you have the training and the skills to evaluate the machines. Ultrasound machines and settings. Once you choose the right machine, then you have to go to the application and choose the lung preset from the list of the application like vascular, abdomen, obs and gynae, and other applications. You need to use all modes in the machines like black and white mode or grayscale, the M mode, motion mode, and color Doppler mode to evaluate the vascularity of any lesions in the lung. M mode is really important to use and should be more frequent, and it is really more frequent than color mode during the assessment of the lung ultrasound. Once you set your machine, you need to turn off harmonic imaging and compound imagings, because what ultrasound actually lung ultrasound relies on artifacts. And these two techniques, the harmonic imaging and compound imagings, will really reduce artifacts. Actually, we need more artifacts to see through the lung, and we'll be able to diagnose. So you need to make it off. Also, you need to switch the filter off. This will help you to have more artifacts, and you'll be able to evaluate the pleural surface actually, and you'll be able to see the different profiles of the artifacts through the lungs, where we discuss it in the next few slides. It's a higher beam frequency yields a higher resolution. So that's an statement means we need to use the higher frequency probe. Linear probes really have better resolution, better image quality than the convex probe or micro convex probes. So these the com probes we are going to use. In terms of probe selections, these are actually available of the market. If you have an access to the macro convex probe, this is really a unique probe, and it can give you actually the combination of the appearance of the curved linear and the linear probe in the same times. So I would really urge you to access this probe and try to use it if you have in your facility or your machine. Otherwise, the combination of these two probes are really useful. So you need to use curved linear probes and the linear probes to cross the lung surface from the anterior part into the lower part of the rib margin. So these are the two probes now we are using in most of our scans. So I would recommend more to use the linears if you have suspicions of lesions and you need to assess the vascularity. And in terms of the artifacts or fluid appearance, curved linear probe actually is more have a big field of view. You'll be able to see the whole liver and lung from the costal margins through the intercostals. In terms of patient positions, the patient is usually examined in supine or semi-erect positions with arm abduction to facilitate the examination to the anterior and lateral chest wall. Lateral decubitus positions or minimal tilting with upper limb moved anteriorly is required to expose lateral and posterior chest wall for the examinations. Also, dorsal region for lower bows are better appreciated in the lateral decubitus positions. So these are important during the scan. So you need to scan your patient in supine positions, in lateral decubitus and dorsal or sitting as well. You need to ask your patient to raise the arm above his head to increase, or her head, to increase the rib space, distance, and facilitate the scanning with the patients in the erect or recumbent positions. The posterior chest is best imaged with the patient sitting upright, while the anterior and lateral chest may be assessed in the lateral decubitus positions. In terms of the area of the assessment or the zones, the international evidence-based recommendation for point care ultrasound for the lung recommendation dividing a lung zone in this fashion. So it takes a sternum border, and anterior axillary lines as the anterior surface of the lung, divided into superior and inferior portions, and which is called zone 1 and 2. And also it takes the anterior axillary line and posterior axillary line laterally, and dividing into superior and inferior portions, and called zone 3 and 4. Just to make it simple, if you know the anatomical location, if you know where your probe is placed, so you'll be able to describe it easily. For example, if you are scanning the anterior superior, so you need to in this area, you need to call it anterior superior area. And if you're scanning lower or the lower portion, then you can call it posterior inferior. So this is the way you need to simplify it to your colleagues and in your actually established center. So these are the 12 points in both lungs. I would recommend you to go through this technique, which is really more recommended. There are others, assessment zone technique and different protocols to use. So this is the most recent and recommended from different international consensus for lung ultrasound. In terms of scanning technique and tips, it's really important to review the patient chest radiography to localize the area of interest. Before you're starting your scanning, you need to have a quick look to the chest and see where is the pleural effusion, where the collapse area, where is the abnormality exactly. Then you can go through it and you can focus your probe on that area. Also, you need to maximize your visualization of the lung and pleural space, which is really achieved by scanning along the intercostal space. Scanning should be performed during the quiet respirations to allow for assessment of lung or normal lung movement, and its recent suspended respirations, when a lesion can be examined in detail with grayscale or color Doppler ultrasound. Also, do not forget to use the M mode or motion mode during the scanning to see the pleural surface or pleural lines and the motions of the lung or the sliding of the lung. On grayscale image, the echogenicity differentiations, or the way we explain the echogenicity, are actually similar to the liver assessment. So we can call it hypoechoic, isoechoic, or hyperechoic appearance. These are the common terminology. We can use it also for lung ultrasound. Before we go to the normal appearance and the abnormal appearance and the scanning technique of the lung ultrasound, I would like to go through important terminology, which I would really recommend you to go through it and understand each one very well. As you all know from the beginning, I have said that we rely on artifact. Without artifact, we cannot really make a diagnosis for lung. It's not like other imaging, like liver or kidneys. We need artifact. Artifact will help us to see the pathology easily. So the first terminology is called A-lines profile, which is multiple repetitive horizontal lines that are parallel to the equidistant from the pleura. So this is the probe surface. This is the subcutaneous skin and subcutaneous. These are the two the ribs, and this is the pleural line, and this is just a copy of the pleural lines through the lung. So these are one of the normal appearance of actually the lung. This can be, other lines may also be prominent in patients with atelectasia, asthma, COPD, positive lung sliding at the line, and pneumothorax, which is negative lung sliding at the pleural lines. The other terminology is the P lines. P lines are the main vertical artifacts. It's really the opposite of A lines, as you can see here. This is, it can be a focal, or it can be a multiple, P lines or beams, artifacts coming from the pleural lines here. These are the ribs, subcutaneous area, where this is the probe, and we can see different or multiple P lines through the pleural surface. These lines move with the pleural line during the respiration and may erase A lines and immediately roll out pneumothorax. So the appearance of P lines actually is an indication of pneumothorax. I'll go through the different, appearance for different pathology in the next few slides. P lines are hypoechoic and narrow, span across the whole ultrasound image without fading and move with lung sliding. More than two anterior P lines are pathological and indicate interstitial syndrome. So a single P line could be considered as a normal. So some other cases or some other literature report has said that more than 2 P lines is really indicative of pathology in the liver, in the lung. The other ultrasound terminology we use it in the lung is the C profile, defined as a hypoechoic subpleural focal image generated by condensed lung tissue without physical pleural line cap. So through the curving probe, you'll be able to see actually the C profile appearance. This actually a lung, when you apply the catheter, you'll be able to see also vascularity through it. And this is the lung, and this is the diaphragms. These we should not see the normal lung or the healthy lung at all. This is definitely an indication of lung consolidation, regardless of the size and the number. So understanding air ultrasound, and understanding the air reflect through the ultrasound mirror-like is the key of understanding how to diagnose lung ultrasound or the lung by ultrasound. So we really should carefully assess the surface and the angle and the size and the movement actually of the lung during the scan. These are so important, lists to evaluate during the assessment of the lung ultrasound. Now I will go through an important, a slide, which actually we should really pay more attention to the slide. A very important concept that you are going to need to understand in this COVID-19 lung ultrasound presentations is the air fluid ratio. Understanding that as we go from A prime profile, so A lines without, this is A lines without a lung sliding, as a possible set of pneumothorax to an A profile. A lines with lung sliding. This is A profile with lung sliding, and this is A prime profile without lung sliding. To a P lines profile, to see line or constellations, and then to the pleural fusions. This is an important ratio or understanding of the appearance of the lung ultrasound. Actually, what is happening is that we are going from 100% air to 100% fluid. A typical with the progression of the disease, such as viral pneumonia, you are going to see this pattern of the disease go from the air to the fluid. As the disease improves, we are going to see the opposite happen. So we are going to, from the consolidation or fluid back to the air, the green arrow. so that, we will start to see in the disease lung things like B lines, pleural abnormalities, more consolidation. As the disease improves, we should see the consolidations resolving. And these pleural lines, abnormalities, and B lines resolving back to an A prime profile. These are a typical or important concept about the air fluid ratio while you're doing an ultrasound for the lung. Now we'll go through the normal and normal appearance of the lung or pleura. So we'll show you step by step diagram or sketch and how we can see the normal appearance. It's really important to scan the lung from the anterior across these ribs all the way down to the lower portion of the lung. And if you have suspicious of any abnormalities, then you can rotate your probe to view and intercostal view between the ribs, which is really unuseful view to assess the lung easily to go away from the rib shadow. These are the two probes we use it, as we said in the beginning, the curvilinear probe and the linear probes. So you'll be able to see the subcutaneous tissue and intercostal muscles. Then you'll be able also to see the rib shadow in here and a pleural line here, the white hyperechoic line here, and then the A profile, which is the normal appearance for the lung. So it is a multiple or duplicated horizontal line across the view of your scan. This is a sketch diagram to show you the ultrasound wave when it's hit the pleural surface, when it's go there, and the rib shadow. And we should also see a lung sliding and lung pulse during the scan. So this is one of the signs of normal appearance of the lung. In some cases, we might see some short vertical artifact like this. We should really, not pay more attention to it. If you see multiple, two or more than and more vertical, this is considered as a B line. So just need to familiarize your eye with the A profile. It is a horizontal line and multiple horizontal hyperechoic lines through the ultrasound field of view. This is another image to show you the two ribs and the multiple or copy lines of the pleural lines down there. This is representing a normal lung appearance. Also, if you do scanning through diaphragmatic area, so you'll be able to see the liver and the diaphragm line here, and a lung artifact at the corner or the top corner of the ultrasound image. And also you might see the spine there, down there, which is a hyperechoic line here. And one of the normal appearance actually to see a positive curtain sign. That's a complete a positive. You will not be able to see.
يعني اللي في الموضوع بالشكل السريع بالطريقه هذه ما يعني اسلك، لا انا قصدي انه الجاستريك كانسر موضوع مهم جدا يستحق انه ياخذ حقه من وعندنا حالات كثيره جاستريك كانسر.
Hello. Are you guys there?
يظهر دكتور احمد بعدين بس غلط ضغط على زر تابع يا دكتور.
طيب الله يعطيك العافيه، اعتذر معلش انه ما قدرت اكمل. Anyhow, with aspiration and inspiration, you should really see a positive curtain sign, as you can see it in this image, and also we see negative spine sign down there at the lower part of the image. So in normal appearance, you will be able to see the spine carefully, and you'll be able to see also the lung over here, and also you might see a pleural effusions fluid around it. And if you scan up there, you might see also part of the lung, and you can visualize the lung and its vascularity. One of the normal signs actually is to apply in-mode motion. In-mode motion is one of the techniques we should really use it during the scan. As you can see here, once you have an image of an ultrasound here, and you see the two ribs there, you can apply the in-mode technique over the pleural surface here, and you will be able to see actually the pleural area, this is the pleural line actually, and this is the lung movement here, and this is the subcutaneous over the pleural lines. And I'll show you an example. It's actually a sea and sand shore sign. This is a typical example to the sea. This is the horizon, and this is the sea, and this is the sand. So remember this as a seashore sign. Once you apply a mode motion, you'll be able to see this technique. If you could not see this technique, either other appearance or movement in here or artifacts over the sand area, then this is an indication of abnormalities. We'll go through it now in the next few slides. This is another image of the seashore line. Now we'll go through different common pathology of the lung ultrasound. The first one is the common pneumothorax, which is actually one of the COVID-19 related disease that's related to the COVID-19. So what you need to do during the scan, you need to scan your patient in supine position. As we said in the beginning, you need to scan it across the whole rib all the way down here, and you need to scan it in different zone here. Try to stick with that protocol and scan all the zones that we just spoke about it. Then you can also, the choice you have, 3 probes, you'll be able to see the same image, the ribs shadow and the lines profile. In terms of image acquisitions, you need to have a good assessment, cephalocaudal orientation, identify the superior and the inferior ribs, try to visualize the pleural line, start medially and then slide laterally, posteriorly. These are the way or the technique we need to use during the scan. Then try to keep this question in your mind. Is there any lung sliding? Is there any lung pulse? Is there any vertical artifacts? If you see, horizontal artifact and lung pulse and lung sliding, that's a normal appearance of the lung. If you see otherwise, no lung sliding and no lung pulse and no vertical artifacts, and there is like a P lines or a visualization of the pleural effusion there, then this is definitely or likely to be a pneumothorax. If you could see also the lung point, okay, which is really at this point between the lung and the fluid in there, then this is definitely or high or likely to be a pneumothorax. You can correlate your finding with the chest X-ray or other imagings if needed. Otherwise, this is established, and this is there is a lot of evidence about this typical appearance of absence of lung sliding and absence of lung pulse and absence of air profile appearance and vertical and lung point appearance. Lung ultrasound or the diagnosis of lung ultrasound for pleural effusion, this is another area we can really investigate. So the choices again is the different probes here. You can use the linear and the curvilinear. So you can use the microconvex and the near and the curvilinear. Linear probe is not really good unless you want to do an aspirations and you are you can see the fluid clearly through the ultrasound. Then you can use it. Otherwise, stick with the microconvex or the phased array probe and curvilinear to evaluate the pleural effusion, because the field of view is really bigger. So then you can have a view for the whole lung and the fluid. What image you need to take? A probe or the acquisition of the image. Probe at the mid-axillary line in the cephalocaudal orientation with slight counter-clockwise rotation. So you need to move it around, across the ribs and go up and down to evaluate the whole lung, properly. Then you need to, your beam should be directed posterior towards the vertebral columns. Identify the lung artifacts, diaphragm, liver, spleen, and vertebral column. Visualize the spine is one of the important factors that should be evaluated during the assessment of the pleural effusions. So pleural effusions is easily visualized. It's just fluid. You might see also the jellyfish of the lung, or part of the lung moving through the fluid there. So I'm sure most of the radiologists can, visualize the pleural effusion easily. So no curtain signs, positive spine sign. The spine is more visualized because there is a good penetration through the fluid to the spine, so you'll be able to see the spine easily. These are if there is curtain sign and negative spine sign here, then there is no pleural effusions, and this is one of the two signs for the absence of the pleural effusions. So I will not go through it. I'm sure most of you know or have experience or scanned lung ultrasound before and have visualized the pleural effusions by ultrasound. We can also apply the M mode to evaluate pneumothorax. Previously, we said there is no motion, the chest wall waves, and there is positive motions of the lung beach or the lung organs. So in pneumothorax, the chest wall still remain constant, and also the lung in the same view, no motion can be visualized. So these are the two appearances that we could see it by using the M mode technique to evaluate the pneumothorax through the the pleural surface. In terms of interstitial syndromes, also we can evaluate it through specific protocol. You need to stick this protocol to evaluate the lungs. We need to evaluate the lung zone 1 and 2 and 3 and 4 and try to actually evaluate it through this manner as well. So these are additional zones that give you more image and more attention, more careful scanning to evaluate the lung carefully. So this is based on a very good paper I've reviewed this morning. So I took this actually, this image from them. The image we need to use actually, or the probe we need to use is the low frequency probe, and the second choice is the phased array probe, and the third choice is a high frequency probe, which is the linear one. In terms of the image positions, actually we need to follow the same manner, cephalocode orientation. Then you'll be able to identify the superior and inferior ribs and gore lines. You need to adjust your gain to maximize the contrast and visualize of the gore lines and the B lines if present. Start medially and slide laterally posteriorly according to the chosen protocol. This is very important to follow a certain protocol, then you'll be able to evaluate the disease carefully. How can we interpret the image? Normal lung, as we said in the previously. So I keep repeating this because maybe some of you haven't familiarized himself or herself with the normal appearance. So normal lung sliding, lung pulse, short vertical artifacts. In terms of interstitial syndromes, there is definitely an increase of lung density. So what will happen, we will be able to see more B lines than usual. So you'll be able to see discrete laser like vertical, hyperechoic reverberations, multiple reflection artifacts, as you can see it here, easily visualized. And this, it's really clearly here represented, and here as well, and we can see it here, multiple hyperechoic vertical lines coming to the pleural surface. And this is a bunch of P lines waveform, being coming from the pleural surface. This is definitely an indications of the interstitial syndromes. If you see more than 3 P lines there and through the intercostal space, then definitely this is an indication of or appearance of interstitial syndromes. So interstitial syndrome can be diffuse or focal, which is plus or minus associated with the finding, change in the lung sliding impulse, gravity dependent or independent patterns. The P line density, is it really single or focal or multiple? And you need to also evaluate the distributions of the P lines. And is there any irregularity in the pleural lines or no? This is a normal appearance of the pleural surface. This is definitely irregular, and there is an air between the intercostal and the pleural line. And is there any subpleural abnormalities or no? These are the appearance of interstitial syndrome. So you need to evaluate carefully. So then we will evaluate also that or ultrasound can or able to diagnose the liver syndrome. Again, we will just go through this one, quickly, because I'm sure time is squeezing me and you. So the same technique, use the carefenal probes and linear probe. Image acquisitions, you need to evaluate, or you need to go through systemic insinuations of the entire chest bilaterally. You need to evaluate the lung, from the anterior and the posterior as well. Also, a poor echoic or tissue-like image, hepatizations arising with the pleural line. This is definitely an indication of the liver syndromes. If you also see the shared sign, as we can see it here, so this is multiple tiny hyperechoic lines within the lung, and also air bronchogram also is another appearance we can evaluate it by the ultrasound. I will leave all the slides. I can send it back to you. You can go through it, in detail. So in COVID-19, this is a nice data set. You can follow it to evaluate patient who's coming for lung ultrasound. Place your linear probe at the 2 points anterior chest bilaterally. If there is A lines and normal flaps, this is definitely normal. No need for any more interventions. If abnormal, there is a B lines or two or three B lines, then this is definitely an indication of consolidations. Then you have to identify the pattern. Is it diffuse B lines or a single or two P lines or three P lines over there? Then this will help you actually to evaluate the disease. Yeah, I can give you the papers and you can go through it, and more detail will be available for you at the end of the slides. And now this slide is important. I know some people now among you, or even in the medical practitioners, believe that ultrasound is not accurate for evaluating lung. However, Liechtenstein, actually, Daniel Liechtenstein have reported a study comparing the ultrasound with computed tomography, and as you can see here, ultrasound is really sensitive and specific to evaluate various lung disease over here. So I would say, from my experience, ultrasound is really useful and it's really very good equipment and can give you a good accuracy or lung assessment and other organs. Now we will highlight some important literatures about using ultrasound and the common or the specific problems that hasn't been actually resolved yet by the researchers. So COVID-19 is diagnosed by reverse transcriptions, polymers chain reaction, RT-PCR, which was actually criticized after reports of poor diagnostic sensitivity. In contrast, alternative diagnostic tests such as chest CT has not been recommended by international and local guidelines due to the several reasons, including poor specificity and radiation risk. Lung ultrasound is an established technique for evaluating lung pathologies. It is very sensitive to the abnormalities in the pleural and subpleural spaces. The initial evidence of COVID-19 suggested peripheral lung involvement at the internal alveoli, which alludes a significant role of lung ultrasound in diagnosis and management. This is actually a summary of several papers. So I can say that ultrasound still, there hasn't been a lot of publication about using ultrasound in COVID-19 and what we expect to see. However, it's really established for lung ultrasound. For other disease, So it could really give you the common disease that associated with the COVID-19. However, there have been several publications describing the role of lung ultrasound in COVID-19, and the publications were divided between simple case studies, letters of opinions, and commentaries discussing actually the potential usefulness for lung ultrasound. However, there is no peer review, papers, and most of these studies have retracted. So only small case studies or even or simple case, serious case studies that have been published supporting the use of lung ultrasound for COVID-19 patients. Hungary et al. Were the first to publish a case series on 20 patients of non-critical patient ED. Most of these published papers were not peer reviewed, unfortunately. All reports above omitted, reporting the severity of the cases. This is vital information as it can be postulated the lung ultrasound features vary depending on the disease development. Regarding lung ultrasound scanning technique, still there is a clear discrepancy in the number of regions screened. So some people say 12 regions, other people say 14, other have really proposed a 28 zone to evaluate or to scan during the scan. The main point actually to use ultrasound actually is because it's really not time consuming. So I can use ultrasound for 2-3 minutes and get more information. If I'm going to spend, scan 12 or 14 or 28 zones, then I need actually at least 10-15 minutes to scan, that zones and get more information and then lose the point of using ultrasound. So still, I could not find really a scientific literature actually suggestions specific zones to scan. However, the international recommendation and guideline so far is 12 zones. So we were going to stick with the 12 zones. We just explained it in the previous slides. Solidarity et al. Proposed an unvalidated protocol to perform the lung ultrasound in COVID-19 patients. They recommended scanning patients in sitting positions when possible using a convex or linear transducers, operating low mechanical index setting with a single focus point on the board. They propose this because they believe that this will give better image resolution and better scanning technique. However, Italian experience actually through Ventricle et al. Describing quality positively and with lung in COVID-19, they note actually the application of lung ultrasound helped in decreasing the rates of chest X-ray and CT scans. This is well published, and it's only a small sample size of the patient, so we can't really rely on a single paper who is suggesting using lung ultrasound or replacing chest X-ray or CT scans. These are a summary of the most of the papers have published, and the difference and between them and actually the locations and the number of patients. As you can see, only few numbers of patients. So really, it's really hard for us as a healthcare practitioners to rely on a small sample size. We need really a good trial papers where we can actually rely on the finding, or actually a systemic review, or a meta-analysis paper that really, summarizing the all papers that are available in the literature to tell us, whether ultrasound is really so or useful or can replace CT scan and chest X-ray in COVID-19 patients. This is the protocols. It's actually a decision tree where we can use it to treat your patient. This is according to Lancet paper. It's really available in the literatures. So it's very simple. Tree, you can go through it. If you understand the different B or A profile, then you'll be able to diagnose actually the pneumonia. Then you need additional tests, like if you have an A profile and sequential venous analysis, 3 veins, and then it could be an asthma or COPD and no pulse. If you have, A prime profiles plus lung point without lung, sliding, then this is the suggestion in pneumothorax. This is very simple tree. You can use it to evaluate the lung sliding and diagnose lung easily. In summary, I would like to say that since the original publication demonstrating the role of lung ultrasound in the evaluation of the pulmonary parenchyma, many studies have shown it is utility and multiple respiratory condition. Most of the anesthesia, respiratory, intensive care consultant have used ultrasound to diagnose their patients on a daily basis. Because of the unique physical properties of the lung, only a careful and systemic analysis of both artifacts and anatomical image allow accurate interpretations of the sonographical findings. And that is one of the unique ultrasounds. It gives you a dynamic imaging, then you can see the properties of the lung moving and the sliding of the lung, the surface, and the different artifacts, which is really helpful to diagnose the lung easily. Lung ultrasound in COVID-19 is not a basic examination, as it requires an advanced expertise in science and patterns. So if you don't have an experience about ultrasound or lung ultrasound, please go get more training, try to scan patients, try to familiarize yourself with the normal appearance, abnormal appearance, then you'll be able to scan COVID-19 patients. Do not really rush yourself to scan them unless you have the experience. Handling the probe correctly over the chest and finding more subtle pathological areas requires some skills that cannot usually be acquired in a couple of days. So please try to train yourself, get more experience and more training before holding the probe. There is currently no validated image scoring system for diagnosing COVID-19. I found only few papers, but still not validated. So actually, this is an area of research. I would recommend all of you to start, establishing a research about scoring, the different pathology using numbers to make it easy for the clinician and healthcare practitioner to follow and then scan or diagnose lung easily. To date, all results provide positive outcomes on useful of lung ultrasound in COVID-19. None of the studies included a control group or reported their finding longitudinally. Moreover, the sample size were extremely small, impeding result generalizations. Lung ultrasound finding should never be interpreted without considering of clinical context. So you need to have other imaging or other lab works to help in chest X-ray. The previous and recent evidence suggests that lung ultrasound could be called for solution to diagnose positive cases and grade their severity. The home message I would like to deliver here today, before I close up, lung ultrasound signs, either alone or combined to other point of care ultrasound technique, are helpful in the diagnosis approach to patients with acute respiratory failure, circulatory shock, or cardiac arrest. Think and understand the anatomy. If you know the anatomy, if you know how to replace your probes, and you know the movement and the physiology of the lung and lung pathology, you'll be able to diagnose easily. Get familiar with the different lung appearance profiles by ultrasound: A profile, A prime profile, A profile, lung sliding, B profile, and C profile. Make sure you get enough training before you're conducting the ultrasound, and please correlate with other lab works and chest X-ray and other imaging before any decision you make. And thank you so much for your listening. I hope I deliver good presentations, and hopefully it adds to your knowledge, and you can use it for your patient. Thank you so much.
يعطيك ألف عافية وجزاك الله خير دكتور محمد السعدي. محاضرة قيمة جدا ومعلومات جميلة، وبالنسبة لنا يمكن لنا راديولوجيست كثير منها يمكن أول مرة نسمعها الأمانة. يعطيك ألف عافية، الله يبارك فيك. نفتح المجال للأسئلة، إحنا تأخرنا كثير في الوقت، لكن نبدأ بالأخوان اللي في الداخل، اللي في حضرموت، سواء في الساحل أو في الوادي. إذا في أحد منهم وعنده سؤال له علاقة بالمحاضرة أو عنده سؤال لأي حالة عندهم في أي مركز من مراكز كورونا، any case, any clinical question، ممكن يتفضلون.
في سؤال سأشوف الآن يقول regarding a mode it should be used all times. I would recommend to use it all time. Yes, a mode is very important. It's really adding to the rest of other modes. It can give you the motions of the lung or the sliding of the lung. So it's really recommended to use it all times.
في الحقيقة عندنا 3 أسئلة يمكن من دكتور خالد بمسهل ودكتور صاحب سلمان ودكتور شاني.
أنا جالس أحاول أنسرت.
شنيني. طبعا دكتور خالد بمسهل تفضل، يمكن تعطي أسئلتك الثانية بشكل مختصر.
الو السلام عليكم.
وعليكم السلام.
حيا الله دكتور حسن، حيا الله دكتور السعدي. هو السؤال الأول كويس دكتور سعيدي هو جاوب عليه. السؤال الثاني هو regarding how to differentiate between البريفرال consolidation. عندنا في الكوفيد اللي هو البايلاترال بريفرال consolidation ممكن تظهر عندنا خصوصا في الايرلي كوفيد، وبتوين البريفرال pulmonary infarction، يعني لما يكون في عندنا بريفرال infarction موجود. فهاو to differentiate between these two conditions as it is present in COVID patients. And could we rely in starting full dose anticoagulant if we see radiological ultrasound sign of pulmonary infarction, because the availability of CT pulmonary angio or other confirmatory for pulmonary infarction or pulmonary embolism is not really available in the COVID healthcare centers? Thanks.
Thank you, Dr. Khalid. بالنسبة لسؤالك in terms of the differential diagnosis of the peripheral lung consolidation, unfortunately in the literatures, as I said in the beginning, there is a few papers and a few case studies only have represented some appearance of the COVID-19 patients. And what most of the papers actually saying is just the normal appearance that we see, or sorry, the common pathology we see in the lung ultrasound. So we can't be so specific whether it is really a peripheral lung considerations, but you can or a complete considerations. You need to view it, you need to scan it from top to bottom, you need to do more research. And this, as we said in the beginning, is still ongoing research, still coming, and I could not find really a good papers give us really the characteristics of audiological signs of a peripheral lung infections or a microvascular thrombosis. Unfortunately, I cannot answer these questions unless we have an evidence-based medicine available, then we'll be able to answer it.
دكتور علي رفعت يدك أول.
Dr. Shan, I'm from Riyadh. Thank you very much. It was really one of the interesting subjects to me because I'm a cardiologist and echocardiographer. We face a lot of cases during this COVID era with white lung. That lung ultrasound helped us a lot during the assessment because we are not using anymore the stethoscope for such patient. So my questions, So if you don't mind, if you can elaborate more on white lung in the chest X-ray or white lung of a patient, is there any differential signs for cardiac, non-cardiac cause of white lung? This matter a lot during the COVID patient, because if you have a white lung in a patient, either to give him anti-failure treatment or go through and treat him as ARDS. So is there any specific signs to differentiate such cardiac from non-cardiac in white lung by lung ultrasound?
Thank you so much. Actually, I summarized my lectures, but there are differentiations available. I can get back to you with the papers that have described actually the difference between the cardiac or pulmonary or other disease. I can send you the paper. It is there, but unfortunately, I could not put everything together today in the lectures because they told me I have 20 minutes, so I stick with the time. Actually, I pass it now. But there is an evidence saying that there is difference between the appearance of the lung in cardiac or pulmonary disease. I can send it to the co-chair or the Dr. Hassan, and they can forward it to everyone.
Thank you very much.
يعطيك العافيه دكتور محمد. دكتور علي. دكتور صالح بن سلمان تفضل.
ايوه السلام عليكم. طبعا اسمح لي اول شيء اشكرك. Let me raise the hat for you. This lecture is really very informative. I learned a lot of things from here, and the message to be taken from your lecture here for our colleagues and friends in Yemen and in Hadramaut, using of ultrasound to differentiate the pathologies in general, not only COVID-19, with ultrasound is really very valuable and very informative. You mentioned that most of pathologies are more than 94% sensitive for the ultrasound diagnostic, flexible, easy to be used, easy to learn, easy to develop the experience on it, and still easy to develop more information about it. My questions was, how are you able to differentiate between the pneumonic and COVID-19 consolidation in the ultrasound? Is there a comparison study between the endobronchial or endotracheal and extrathoracic ultrasound for the consolidation pathologies of the lungs? Before 2 days, the American Society of the Pulmonary Diseases published a case report how the CT scan missed an metastasis in the lung and could be detected with the ultrasound of the lung.
Thank you so much, and thank you for the, the highlights of the importance of using ultrasound as a sole tool, and we can't say that ultrasound is superior to the, CT. However, ultrasound has really أنا ما قالوا أثبتت نفسها يعني have proven and it's very valuable tool and can replace CT and chest X-ray in occasion times, and in terms of the differentiation of the disease, we are able to say that is a pneumothorax, and we are able to say this is consolidation by ultrasound. But in terms of the COVID-19 and patients, still, I said to you, only case reports are published. The only problems for me and you and everyone here, we can't really rely on a single case report to diagnose. Still, maybe the other, peer review papers that can really give different appearance or different pathology. However, in terms of the accuracy of ultrasound, yes, it's accurate, it's really good. It is really valuable, and I would encourage everyone really to practice, the ultrasound, and then you'll be able to see the different pathology, and you can diagnose different, different pathology through different appearance. Considerations is easy, can be seen through the intercostal regions, through the lung. Then you'll be able to see the lung. And more visual, more with the fluid around it. Thank you so much.
The message from your lecture for our friends there, you encourage us, you encourage the people in Hadramaut, in Yemen, and all developing country to increase their experience and increase their skills to learn the ultrasound, because it is easy to use, it is easy to develop, and it is really a very promising skill to diagnose not only consolidation or pneumothorax, but to diagnose many things. From my field of neurosurgery, pediatric neurosurgery, the ultrasound of the brain still for us the #1 choice to diagnose many pathologies for pediatric neurosurgeons and intraoperative brain surgery. I encourage all colleagues in Hadramaut. I hope the university is listening to us to start our thinking about this thing, to send somebody to some countries to start developed countries to learn how to use the ultrasound in different fields in the medicine.
As you know, Dr. Allah يحفظك and Khalid, and most of the fellowship programs now in the world now, they have an intensive training of ultrasound through their, career. So they will go through an ultrasound training. The intensive care unit, ER now physicians, they have to have or fulfill, requirements of the degree. So they have to go through an ultrasound training so they can be able to diagnose different pathology in the ER. I will not say about radiology, but I'm talking about the other obs-gynae now, vascular, cardiology, all, healthcare professionals now, they use ultrasound. So everyone should use it. What is really recommended here is to establish a training program. A training program you can, establish in the university or in the hospitals. So most of the physicians can go through rotations to the radiology or even in the ER. Colon expertise to evaluate them and a monthly basis or weekly basis. And by this, you can spread the knowledge, spread the information, and actually attract people to use the ultrasound. I'm sure most of physicians now, they use it and love to use it as a second tool there to their clinical assessment. So just imagine if you are using a stethoscope and just listening to something, but you have the alternative where you can see and hear, which is really better if you are hearing and listening to something, then this is advanced, technique will help you to diagnose then, and the management will be better for your patient. Thank you so much all, and I'm really sorry I could not give more because of the time, and hopefully next time we'll be able to elaborate more and explain more other pathology. And thank you so much all.
Thanks a lot, Dr. Muhammad. See you next time, inshallah, soon.
Allah يعطيكم العافية. شكرا. السلام عليكم.
Thank you all. And any other question related to COVID-19 or any update or any clinical question or case question? Dr. Salim Karama.
الو السلام عليكم.
عليكم السلام.
دكتور حسن كيف حالك؟
حياك الله يحفظك.
معلش I want to add some points about the white lung in COVID patient. There is question asked about how to differentiate between اللي هو ال RDS اللي هو cardiogenic and non-cardiogenic. By the ultrasound is the picture of اللي هو ال RDS اللي هو ال cardiogenic or non-cardiogenic is the same. But we cannot differentiate by ultrasound between cardiogenic and non-cardiogenic. The main differentiation point is by pulmonary artery wedge pressure technique. If more than 18, it is a cardiogenic. If it is less than 18, this is the lung disease or primary lung lesion. Okay. Also in the lung ultrasound, there is one point اللي هي weak point اللي هي B lines. B lines is the same in acute illness and also in the chronic illness. In COVID patient, they give the same B lines is for both lateral, for both lungs and basal. You cannot differentiate between this patient is congested or this is interstitial induced by COVID, or this patient is also cardiogenic. This is the point. Also, the ultrasound of the lung is very important in ICU in case of weaning of the patient. The diaphragmatic excursion is very important to decide this patient is winnable or not winnable. Also, by the ultrasound, you can see the intercostal muscles movement after the deep sedation and neuromuscular blockage. I will talk about the point of the consolidation. Consolidation and pulmonary infarction are the same by the ultrasound. Subpleural infarction or subpleural consolidation due to infection is the same. But some said that using of the Doppler technique in this consolidated area, if the Doppler is positive Doppler, this is may be infectious. Infections induced consolidation. But if the Doppler is negative and no flow or no blood flow to this area, by the Doppler, this means highly probably to be an infarcted area by the ultrasound bedside. Also a very important point to اللي هو الاير برونكوجرام اللي هي الconsolidation mode by ultrasound اللي هي C mode. If the air bronchogram is mean white picture in the ultrasound picture, but when you see the fluid bronchogram اللي هو black tree, this is the very important to be interfere with this patient. Means this is patient enter in collapse. This patient in need for emergency bronchoscope to relieve this collapse. This is the very benefit from ultrasound in COVID patient. Also, I want to talk about the hemodynamics for the COVID patient. As we know, the patient in ventilator or in COVID pneumonia should be in negative balance fluid. So we will follow this by ultrasound. It is better by chest ultrasound daily, and also inferior vena cava pressure measurement. Also, if you have a good cardiologist to measure the stroke volume daily, and also for renal perfusion by the Doppler. Give a very beneficial points for this patient to make a good hemodynamic balance for COVID patients. And thank you very much, Doctor.
يعطيك الف عافيه دكتور سالم. دكتور سالم باجهام، الله يحفظك ويعافيك. شكرا.
الله يحفظك يا دكتور، شكرا جزيلا.
Any other comment or any question in general about COVID-19? أجل نختم إن شاء الله. والأخوة اللي ما تمكنوا يدخلوا على الإنترنت أو واجهتهم صعوبة في الدخول، إن شاء الله يجروا المحاضرة مسجلة على الفيسبوك، وأي وقت يسمح يشوفونها. بارك الله فيكم وجزاكم الله خير الجميع، وكتب ذلك في ميازين حسناتكم، ونشوفكم إن شاء الله السبت القادم.
يلا الله وجهكم جميعا.
في أمان الله.
السلام عليكم.